Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. Perfect. Well, top of the hour, happy Thursday, everyone. Welcome to Mountain West AETC Echo. Super excited to have a very special guest back with us. Dr. Raphael Landovitz from UCLA has joined us a couple times over the years in Echo, and we are very appreciative for sharing your time and expertise. For those of you who don't know Rafi, amongst many things, is professor of medicine at UCLA and has helped lead the thought, the guidelines, the innovations around HIV pre-exposure prophylaxis, and very impressively, this phase 3 clinical trial, which we have talked about, that looked at IM cabotegravir versus oral FTC TDF. So, Rafi, welcome, a huge welcome for myself and the entire community. Thank you for your time. What we would like to do to frame this for everyone is really keep this open and informal. We've reviewed the data from the HPTN 083 study previously and sent the slides around. We'll have them up for some reference, but really I'm going to start the conversation with Dr. Landovitz, and then please feel free to jump in with questions, comments, shoot a hand up, get my attention, unmute and jump in, or feel free to put anything in the chat box. Rafi, as we start, one of the things that I think is so impressive about the 083 study is just how big a study it was. It must have taken a Herculean amount of time and effort and enormous teams around the world. Just anything you could share with us about how you were able to bring this together and make it happen and what it took?
So first of all, Brian, thank you so much for that really kind introduction, and thanks to the ECHO community for welcoming me back. So 083 was a huge effort on the part of HPTN, right? The AIDS-funded network that organizes large prevention efforts across the world. And so they had a network of sites that were core funded by the NIH. And when we were thinking about this particular study, what we were really aiming to do was trying to find a product that would bring more people into PrEP and provide additional prevention opportunities for people who had challenges for the use of a pill-based prevention strategy. So when you sort of look at both clinical trial and observational data, that very specifically identifies younger MSM, Black and Latinx community MSM, and transgender women as being particularly challenged at both accessing, adhering to, and persisting with the currently available biomedical prevention strategies. So we wanted to make sure that we had representation sufficient in this study to make these results generalizable to those populations. So that required bringing in some additional protocol-specific sites in addition to the large cadre of sites that the HPTN already had collaborated with. So we sort of went looking for sites that had access to these populations and an interest in participating in this, because I think, it takes a specific level of community engagement to be able to describe why, when you have a highly effective product, you're going to ask people to take a chance on something that's investigational, particularly when the messaging tries to be that when taken as prescribed, TDF-based PrEP is so highly effective for HIV prevention, arguably greater than 99% protective. So why would you take a chance at something that could virtually only be less effective than that? And I think the observation is, right, efficacy versus effectiveness. A highly effective drug is not efficacious if you don't take it. And so is there room to improve in the efficacious aspect of PrEP in that way? So that was the approach. And it was a huge community engagement effort at 43 sites in 7 countries. That was, some things take a village. This took a metropolis, we like to say, to pull off. And so it really was a team effort. So I can't take too much credit single-handedly, but it was a behemoth effort.
It is a incredibly impressive effort. I wonder, Rafi, just pausing on that for a moment, are there lessons to be learned for other clinical trials, whether they are PrEP or HIV treatment or others?
Well, I think, Mitchell Warren and the AVAC team have sort of called this out specifically, and our team has been given a lot of kudos for the representation that we were able to get in this study. So, the US population was 50% Black or African American. The overall population was 12% transgender women, and 2/3 of the population were under the age of 30, and 40% were actually under the age of 25. So, meeting the NIH definition of adolescence. And I think it sets out, it depends what you commit to. If you say, not just we would like this to be true, but we're going to mandate that it be true, and you have the resources to do the community partnering that those metrics require, I think anything is possible. And I hope that it's a call to action for other studies to devote appropriate resources to making sure that that community engagement and collaboration happens such that this can be sort of a new standard.
Absolutely. I think that's a really important message. Thank you very much, Raphael, for highlighting that. Maybe if we can focus on the trial design and protocols for a moment, and there's a reminder on the slide next to me there. And if anyone has questions or comments you'd like to ask about the design and protocols, please feel free to weigh in. You can put any questions or comments in the chat box. And then we'll go next to results and what they mean and outcomes in the future for sure. But Raphael, one thing that I think is important to discuss about the design is that oral lead-in and then that long oral tail for individuals when they finish either arm, but particularly when they finish the long-acting oral injectable. I'm curious to ask you any comments you could make about the thought that went into how much, what duration of lead-in and tail was given. I'm sure, I have a feeling a lot of thought was given.
There's a lot of machination. You're right. So when both 077, which was the phase 2 study that we did before 083, was being planned, the cabotegravir was still a fairly new chemical entity. It was before a lot of the therapeutics trials that were done in combination with long-acting rilpivirine for maintenance of virologic suppression. So a lot less exposure and a lot less of an understanding of the pharmacokinetics at that point. We had a long discussion with the regulatory agency, the FDA, about what was the appropriate short-acting preparation, that is pill-based lead-in, before exposing someone to the long-acting version of the drug. And that was even before the terminal half-life had been as well characterized as it is now. But this notion that it was at least 48 weeks was there from phase 1 studies. And, early on, when you have small numbers of patients, there are various blips in safety signals that can give one pause that aren't borne out in larger trials with more exposures. And so the FDA was very concerned that there were not a lot of exposures. And the original concern, anyone who participated in the phase 2 studies will remember this, about some LFT abnormalities that were observed early on in the development process. And was this going to be an important signal? And the FDA originally wanted us to do a 16-week oral lead-in in that phase 2 study. And we had a long conversation about that being sort of antithetical to the idea of those who would benefit most from a long-acting injectable preparation. If you're going to say you have to use this as a short-acting daily pill for 4 months before you get an injection, then you really don't have a product that addresses a need. So we sort of were able to have a conversation about restricting the entry criteria and the progression to the injectable product criteria based on safety labs during the oral phase, that we compromised at a month. And that seemed reasonable. And the phase 2 data, in fact, supported that going forward as a reasonable approach. And so that's what we carried into the phase 3 studies, that 4-week interval. And now with lots more exposure, both in the therapeutics arena and in the prevention arena, we're actually moving towards a posture where the oral lead-in will be considered optional. At least that's what we're sort of hoping to move towards. There are ongoing discussions about that before it's final, but that's where we're hoping to get. Because, I think, again, being true to the populations that we think will benefit most from a long-acting injectable, again, still antithetical to that mission to force someone to have an oral lead-in beforehand. So one of the things that we're hoping to integrate into the next phase of 083, in fact, is we're hoping to be making that oral lead-in optional. So an investigator or a consumer might say, for X, Y, and Z reason, I think it would be safer for this person to have a month of short-acting exposure before going on versus going directly to an injection posture. So I think that would be important to get data in that space, because I think hopefully if there were to be a regulatory approval, you would want that flexibility, because I think no one ever intended for this to just be another daily oral medication. So that's sort of how we got to this. And of course, we're looking carefully at the 083 data to see if there really was any sieving that seemed to be appropriate from that oral lead-in, or was it just actually something that could be potentially a period of vulnerability. If you saw the AIDS 2020 presentation, 3 of our 13 seroconversions in the cabotegravir arm occurred during that oral lead-in. And so like with TDF-FTC, where we know there, depending on how you dose it, somewhere between a 2 and 5 day onset period to maximal protection, cabotegravir likely has an onset to protection element also, particularly around the oral dosing, and we don't know what that is. So if someone were to be exposed either on the day of starting or early on in that exposure, could that be actually a vulnerability to the strategy? So I think having the opportunity to remove it might be advantageous for a number of reasons, not just the need for adherence to daily oral pill. And then just, I don't know if you have thoughts about that, and then I want to talk about the tail, because you had asked about that also, but let me stop.
Well, if anyone else has thoughts too, please feel free to jump in. I, on the one hand, absolutely see the advantage of removing that lead in. And I think your point is certainly resonating with me that that might be a barrier to some of the people who would really benefit from this. A theoretical reason for the lead in that I've heard is to ensure tolerability, because cabotegravir and similar drugs are so long acting. So can I put the question back to you, Rafi? Where did those discussions go about tolerability? Cabotegravir seems like a very well tolerated drug, but if someone did have a side effect, there's no way to remove it, right? So
Right.
How would you address that concern?
Right, and that was the whole theory for why we did the oral lead in the first place. But the question is, how often do you see a serious toxicity with the injectable? And if you do, then what's the likelihood that you would have detected it with the oral, right? Because if it's not an appropriate sieve, then what's the point? And that's always going to be a liability of an injectable product. And we have a number of other drugs that we don't have an oral short-acting version of, and we go into them, right? I mean, just the monoclonal antibodies, as an example, right? I mean, there's no oral equivalent of them. And you say, well, in theory, they should have limited toxicity, but you could always have an infusion-related reaction, an anaphylactic reaction. And so I think there's always an intrinsic risk with a long-acting product. And the question is, what's the rate of those events, and how sure can we be that this is safe? Because you're right, once you deliver the injectable product, there is no removing it. It's not dialyzable. You can't surgically excise a depot that's been implanted. It diffuses through the belly of the muscle, presumably, or the space that it's injected into. And the only thing we found that sort of accelerates metabolism is sort of rifamycins, which probably wouldn't be an effective elimination accelerating strategy, just because even if you accelerate the elimination, you still have a depot of it that's in reserve in the muscle belly that's being released at a constant rate that would not be accelerated in its metabolism by that, because it's not reaching hepatic metabolism until it enters the bloodstream. So we really don't have any effective way to remove it once given. So it is a concern. But I will say in 083, we didn't see any show-stopping toxicities. And again, right, this is only about 2,200 people who received the active cabotegravir injection. And what are you going to see with increased use? Could you be missing rarer events? Absolutely. And that's why I think the optionality, if that's a word, of the oral lead-in is a flexible way to address that.
I support that word very much. And I find it to be very positive just to know that it is a potential to remove that oral lead-in, which could be a barrier for some. And it seems like an excellent point that it was so well tolerated that that might give us optionality. I would imagine that may be different when we start talking about long-acting cabotegravir rilpivirine for treatment, in which there may be benefits to reducing someone's viral load before starting. So there may be other considerations for the oral lead-in there. Rafi, do you want to make comments on the tail, and then we'll see if others have questions about protocols and process here before we turn to results and implications?
Yeah, no, absolutely. Just the one thing I would say about the treatment space is remember that currently no one's proposing long-acting right out of the box when people are viremic, right? So everyone has to be virologically suppressed when they transition to the cab-rilpivirine regimen. So the question of whether you need an oral cab-rilpivirine introduction to that injectable I think also is in play, right? And I believe that one of the ViiV phase 3 trials, and I'm always forgetting which one it is, it's either Atlas or Flare, there was a small component of participants that they allowed to quote unquote direct to inject. So they were virologically suppressed on their more conventional regimen, but they did not then have to convert to oral cabotegravir for a month before going to the injectable. And I don't know if those data have been presented yet, but we're going to get some information about that strategy in the treatment space. So the tail we characterized in 077, the tail phase pharmacokinetics, and it was sort of interesting. The median time to undetectability of cabotegravir, if that's a word, at the lower limit of quantitation of 25 nanograms per milliliter for individuals born male was about 43 weeks. And for individuals born female, it was about 67 weeks. So, I think that sort of makes people's eyebrows go up because of the length of both of those. And what's sort of more interesting is the pharmacokinetics of this drug it's a little unpredictable. There's high variability in these terminal pharmacokinetics. And so the range of values that we saw in modeling time to undetectability for the individual born female went out to 4.5 years at the outer end. So, the implications of a pharmacokinetic tail of 4.5 years after your last injection is not trivial, right? You're asking someone to commit to something that could be in their system for the next 5 years. And so implications for pregnancy, for breastfeeding, for drug-drug interactions, for toxicity, all are things that need to be considered for this product. And, when we tried to figure out the predictors of this high rate of variability in the terminal pharmacokinetics, really the only two things that we were able to identify was sex at birth and BMI. And together, those two characteristics only accounted for about 10% of the variability. So there's a lot that we don't understand. If I were a betting person, I would put money on that the delivery of the injectable product does not always land where we think it does, that delivering a gluteal muscle injection is more of an aspirational delivery mechanism, and that some measure of it may end up being delivered subcutaneous, intramuscular, some even retroperitoneally, depending on someone's habitus. So I suspect that there's a component of that is contributing to these variabilities. And I think until we understand that better, it's going to be hard to characterize fully. But I think that's one of the elements of this drug that is an opportunity and a challenge, right? I mean, what's great about this drug is it lasts a really long time. What's problematic about this drug is it lasts a really long time. And the consequences of being exposed to HIV in the prevention setting or defaulting from HIV treatment using injectable strategies in people living with HIV, it's both the Achilles heel and the advantage, and sort of understanding sort of the nuances of what that means, I think is going to be critical to optimally using these strategies.
Absolutely. Thank you so much, Rafi. To David Spock, I saw your question in the chat box. David, would you mind unmuting briefly and asking that question?
Right. So, Rafi, I was just asking, when you did the study, how effective was the oral lead-in and essentially in picking up toxicity? So did you actually have some people who had significant toxicity during the oral lead-in that you had to prematurely stop the study? In other words, is that actually a pretty good filter at filtering out toxicity?
Yeah, it wasn't great. We had adherence requirements to the daily oral pill by pill count in order to progress to the injectable phase. So we had about 5% of people who weren't able to adhere to it with sufficient fidelity to progress to step 2, because we sort of mandated that there be sufficient exposure to determine if there was toxicity before progressing. And the rest of the 5% were fairly rigorous stopping criteria, again, based on changes in LFTs or any grade 4 laboratory or clinical abnormality that happened. So, it was a smattering. There was no one thing that fell out as a signal. It was a smattering of events that it turns out, now that we're unblinded, were not different between the two arms in that oral lead-in phase. So it didn't seem to be a particularly good sieve for filtering people out for toxicity that seemed to be drug associated for the investigational product, which is why I think the agency and ViiV and we are increasingly comfortable with making it optional.
Very interesting. Thanks so much, David, for the question. Before we turn to results, which are exciting, intriguing, promising so many things, Rafi, one of the things I'm hearing in the background is just the question of who might be the best candidate for long-acting IM CAB for PrEP. And I wonder if you could make a comment, and we'll pull up the results for everyone to remind themselves. Who do you see, who do you imagine might be the best candidate for the drug? And then also, how much concern does that long tail you're talking about give you in terms of an individual who might miss a dose or fall out of care and continue to have elevated risk for HIV infection?
Are you asking me that question? Or you're asking the group to comment on who they would think about this from?
We would love to hear your thoughts first, if you are willing.
No, sure. I mean, I think what my take-home message from 083 it could be summarized in this way. Both strategies are highly effective when taken as prescribed. And, Truvada, I think we all have this sense that it's extremely forgiving for rectal protection. And again, I'm going to be hyperbolic and facetious here, but if you're in the same room as a Truvada pill on a regular basis, you're going to have high levels of rectal protection. And of course, I'm being facetious, but we do know that the sort of anticipated risk reduction from even 2 doses a week would be, in the 75 to 80% range. So it's highly protective, even if taken with that level of irregularity. But there are a cadre of people, and we have form-fruit evidence of 39 of them right here, who were not presumably taking TDF FTC with sufficient fidelity and whatever that means to have protection, and therefore they got incident infection. And for those people, it is clear in my mind that cabotegravir provided better coverage of the sex acts, right? To me, I don't see any information yet that says that one agent is more potent than the other. And I'm using the agent term here as the aggregate of TDF and FTC, right? Because that's what we compared. But to me, the take-home message is for people whose lives are particularly risky and chaotic, using the CAB, we're able to cover these sex acts with an agent that has prevention efficacy more effectively than TDF FTC for these people. So to me, the message is if you are good at pill taking and you are able to either be directed with a 2-1-1 sort of strategy or adhere to a daily oral intervention, that's fantastic. If you are challenged by that or think you will be challenged by that, then here is another highly effective product that we could offer. And to me, the message is choice is good, more options for people to be able throughout their lives to go between daily oral, event-driven oral, injectable, just has the potential to bring more people to the prevention discussion. And so if there are people who said, I'm not going to take a daily pill and my sex life isn't predictable enough that I could do on-demand dosing, but I could show up in some doctor's office or some pharmacy and get an injection every 2 months, and it brings more people to prevention, I think that's where this has the potential to be extremely powerful at a population level.
Absolutely. That message right there seems so clutch and key. We're displaying the results here, but I think, Rafi, that interpretation right there was just really powerful and meaningful. So thank you for that. Perhaps what I'll do, Rafi, is I'll ask you one more question, and then we'll open it up to everyone in our ECHO family here, see what other questions, comments, discussion points people would like to raise. I guess, Rafi, just building on that message you just shared, what do you see as next steps, both for CAB and research and FDA review and approval, if you're able to make any comments, and then also the future of long-acting PrEP, where are we going?
Yeah, so all great questions. And again, I'm going to be a little bit tongue-in-cheek here. My crystal ball is cloudy, so I don't know. But I do think we're moving to an open label extension phase in 083. So I think it'll be very interesting to see how this behaves without people having to take a placebo tablet in addition to the injectable product. I think it'll be interesting to see the tolerability profile. I think we need a lot more experience with figuring out how to get people off injectable or when they decide to stop taking injectable. Right now, we're covering this tail for 48 weeks with daily oral TDF FTC. And the question is Is that necessary? What does that mean? And I guess the way I'm thinking about it currently is if someone is ongoingly at risk for HIV acquisition, then they need to be on a prevention product that's highly effective, be that daily oral TDF FTCs that come off the injectable, be that condoms, be that abstinence, be that whatever, to keep themselves uninfected regardless of this cabotegravir issue. So to me, the primary goal should be keeping people HIV negative. Then a distant secondary goal is prevent people from acquiring HIV that could potentially be resistant to integrase inhibitors. But the first one is so much more pressing than the second one that I think that should be the focus of the conversation. So I think that needs to be sorted out. And I don't think 083 nor the open label extension is going to have sufficient events to be able to fully scientifically and rigorously answer that question. I do think one thing we talked about in the AIDS 2020 presentation that sort of got glossed over a little bit were the delay in detection of these infections at the site level compared to the more sensitive central testing that was done at the HPTN laboratory center. So I think the question that we sort of got an introduction to in the randomized TDF FTC PrEP studies, this notion of ARV-based PrEP delaying conventional diagnostic assays and reducing both viral loads and delaying antibody response and antigenemia, and delays in detection have a different flavor with a long-acting product. Because you could say, well, if they're not viremic, does the matter of delays of a little bit with a short-acting PrEP product matter? Because the likelihood that they're going to be viremic and therefore have ongoing secondary transmission or generate resistance really matter, maybe less. With a long-acting product, what does it mean? Are there going to be more cases of delayed detection? What is that going to do for our testing algorithms, especially in resource-limited settings where more sensitive testing may or may not even be available? What are the implications of that delayed detection and the rate of false positive testing in at-risk individuals having multiple episodes of testing? Because no test, of course, is perfect. So I think it's going to really push us to think about diagnostics and push the envelope, both in resource-rich and resource more limited settings, to really think proactively about what all of these long-acting agents, both cabotegravir as a sort of a canary in the coal mine, but future agents as well, including, depending on what we see with this latravir in the PrEP space, or implants or monoclonals, to our diagnostic ability and what the implications of that for ability to suppress subsequently. So I think that's really critical to the field that's going to need to be advancing with products. So I think that's as sort of far as my crystal ball goes for the future. I think we're all awaiting the 084 sister study results, right? 084 is the similarly designed study in sub-Saharan African cisgendered women that is ongoing. They started about 11 months after 083, so they're about a year behind us. They're nearly fully enrolled now, and their next DSMB review is in November. And so obviously we're eagerly and hoping for similar results that we saw in 083 for cisgender women. And, I know that ViiV is considering all their options at this point about filing strategies with 084, without 084, waiting for 084, because obviously I think people would like a drug that has shown efficacy across populations. But when you have a superiority result like this, do you wait? And how long do you wait? So I think there's a lot of things at play here, and it's going to be interesting to see how that plays out.
Thank you, Riffy. And I very much appreciate how you are presenting the optimism and all the excitement around it and the concerns. Perhaps I will add one more question because I'd really like to know your interpretation of the weight gain results from 083. And then I will shut up and open it up to everyone in the community for questions or comments. And
Can I push Rafi before you move off the topic, which is, Rafi, you gave me, and I know that you're willing to give me some more hypothesizing, but you had some hypothesizing about when we might see this. So since most of us don't do FDA approval and timelines and things like that, just give us a hint of what you think we might see this if it were to go forward.
So Joanne, I honestly don't know. Kim Smith, who is the VP from ViiV, who's sort of speaking on the program's behalf, did make a public statement that she's hoping for an FDA filing in spring of 2021. So she's made that statement in the public space. So I think we can take that for what it's worth. That doesn't give us any insight into, is that assuming there's 084 data to go with it, or assuming there isn't 084 data to go with it? So I don't know more than that, honestly. So, if there were to be a submission in first quarter of 2021, again, hypothetically, right, one would presume that it would get priority review and we would have an answer 6 months later.
Thank you, Rafi, for letting us push you. Rafi, what do you make of the weight gain findings, and then opening up to everyone, and we'll do our best to be sensitive of your time and wrap up within 5 minutes or so. Rafi?
Yeah, no worries. And Joanne, you can always feel free to push me. I'm not standing by a cliff, so you can even push me if I were standing by a cliff. So the weight gain issue, right? So it's sort of been an interesting trajectory, right? Our phase 2 study, this 7 study that I keep referencing, right, was placebo controlled, and it was global and men and women. And we saw no difference in weight change and metabolic parameters in the active versus placebo arms there. But that was a small study, right? That was just under 200 people. And here in 083, right, we saw this interesting finding where the weight was measured more rigorously than it was in 077. It was measured in a standardized way, which it was not in 077. And we saw the statistically significant difference in weight gain in cabotegravir compared to the Truvada that seemed to be driven by really the first year, the events of the first year, where the weight increase and the annualized weight increase in the first 41 weeks of the study was 1.5 kilograms in the cabotegravir arm and 0.5 kilogram weight loss in the Truvada arm. And after that, it was basically identical. So it seems to all be driven by this weight loss attributed to the Truvada in the first year. And I think that's consistent with other studies, both in the treatment and prevention space. And it's interesting to hypothesize if that could be attributable to some of the early onset nausea, vomiting, sort of GI startup syndrome. But it doesn't just seem to be limited to that first 2 to 4 weeks, which is what is a little bit provocative. And, I know people are hypothesizing freely and very interested in understanding what a plausible mechanism might be for these findings as a class effect. But I think it's interesting, but it seems like it's being supported by increasing amounts of both randomized and observational data that this integrase class thing is real. And, we do have fasting metabolic parameters in 083 that we're analyzing still. So we'll have a more full package to understand what the potential metabolic consequences of this weight increase difference are. And obviously, in both the treatment and the prevention space, that and its effects on cardiovascular morbidity and mortality, I think, are what we're all worried about in the back of our mind. But I think when you have these conversations, including around TDF-FTC versus TAF-FTC for PrEP with consumers, this looms large as something that's very important to them. Everybody that I've talked to here in LA about potentially, they come in saying, I heard about this safer, better PrEP oral drug. I want to talk about it. And when you sort of have the conversation and lay out, the risks and benefits of each strategy, most people point to the weight gain issue as why they ultimately decide not to switch. And, maybe that's, an LA thing, but I suspect it's something we all think about. I mean, in the time we've been sitting here talking, I feel like I've gained weight. So I think it's something we all struggle with. But I think the truth is, as people age, they gain weight, full stop. And so it's going to be difficult to tease out individual effects. And as we understand mechanisms better, I think it'll help us clarify what this means. But I think it is an important thing for consumers.
Hot topic, complicated topic, definitely not limited to LA by any means. So how about in the last 3 or 4 minutes before we turn to cases, let me open up to everyone in our ECHO family, wherever you are joining from. Please feel free, put up a hand, type in the chat box. Questions, comments for Dr. Landovitz. We are very, very lucky to have Rafi joining us today. Just rare to get someone with so much insight into such a landmark study. So questions, comments, I'm going to pause for a moment and see.
Usually when it's quiet, it means either I was so incredibly clear that no one has questions, or I was so incredibly boring that people are actually asleep and multitasking, checking their Facebook.
It was the first one, I promise. 100% guaranteed. No one in our community ever does that.
Check and see if Joanne posted about her daughter on Facebook in the last 5 minutes. I dare you.
Questions, comments. I'll give another minute, see if anyone wants to jump in. Otherwise, I certainly could talk about this all day. Maybe then, Rafi, I think everyone is mulling. I see wheels turning, everyone processing. Lori, I see you unmuting. Lori, do you want to put a question or comment out there?
Yeah, going back to the long tail when we're thinking about populations, I know a lot of people have thought about using this, for example, in women who are concerned about stigma or being discovered, often in like either African immigrant populations or over on the continent. And again, I guess a question is, how much would you rule out giving this as a prevention method to people who are really going to be unlikely to really cover that tail with oral medication after? I know you touched on it a little bit in the beginning, but how much do we really need to think about? If you can't take a pill, then really we can't give this to you because you're going to be at risk if you decide not to do this anymore and your risk doesn't change.
Yeah, it's a great question. And I think one of the huge advantages of this, as you were essentially saying, is the discretion of it, right? You don't have to be seen carrying around pills that could be stigmatizing, that could put people at risk, for violence or being stigmatized in other ways. And so I think the question comes back to, can we leverage another highly powerful prevention method? It doesn't have to be a pill, right? The vaginal ring is getting approval in Europe. It hasn't come to, adjudication here for approval in the US, but, if that's an option, that could be part of a prevention strategy. I guess the questions that need to be answered is, number one, we need to more fully understand the consequences of seroconversion through the tail, and we don't know that yet. And also, if that does turn out to be an issue, what other prevention mechanisms can we bring to bear to keep someone from getting HIV during that tail period? It doesn't have to be a pill. So sort of two sequential questions that we need the answer to fully be able to answer your concern. But I wouldn't not give it to someone because of the concern that you couldn't cover the tail later.
Well, I really appreciate that question. Rafi, last questions, and then we will thank you and let you go about all of your work. So one, are there any comparisons between IM-CAB and FTC-TAF in terms of efficacy or the weight gain issue? And anything you can tell us about when we might see data on the mutational analysis, the resistance studies for those who failed while taking CAB?
Yeah, so thanks for that question. So no, there have not been any head-to-head TAF FTC CAB comparisons yet. I'm sure you're going to see them coming in the future, but not yet. And the question of when are we going to have the resistance and drug level data? And the answer is, I hope to be presenting it at a large infectious disease conference in the coming months.
Rafi, thank you very, very much. We have overextended the time we asked you to give. We are very, very appreciative. I'm going to ask all of my colleagues and ECHO family members to join me in giving you an ECHO applause. Thank you so much for all the work that you do and for joining us and sharing your time and expertise. Rafi, we're very, very appreciative, and thank you very much.
Thank you so much for having me. You guys are awesome, and it's always a pleasure and an honor. So thank you.
Thanks, Rafi. Take care.
Take care.
Thank you for watching this edition of the Mountain West AETC Project ECHO Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.